Support for Arkansas Week provided by the Arkansas Democrat-Gazette, the Arkansas Times, and KUAR-FM 89.
Hello again, everyone. Thanks very much for joining us. 2 months after a mysterious virus made itself felt in the Pacific Northwest, Arkansas recorded its first case of what we now know as COVID-19. Today, 4 months later, more than 26,000 Arkansans have been infected. Now, the vast majority recovered. More than 300 did not. In addition to the cost in human life and well-being, the economic impact here as elsewhere has been staggering, and the curve has not been flattened. It's the clinical aspect that's our focus in this edition. At Midsummer, Arkansas and the coronavirus, what we know, where we may be headed. Joining us are Dr. Joe Thompson, president of the Arkansas Center for Health Improvement, Dr. Jennifer Dillaha, director of Outbreak Response at the Arkansas Department of Health, and Dr. Cam Patterson, chancellor of the University of Arkansas for Medical Sciences. Our thanks to all three of you for being with us. Dr. Patterson, I would begin with you. You and your colleagues at UAMS this past week have compiled and released a new model for where the state might be headed. And after reading or trying to comprehend all 21 pages, I would say that our options range from the not very good to ominous. Have I summed it up pretty well?
I think you have, Steve. It's a sobering prediction. It is a prediction. It's based on our staying at steady state in terms of social distancing and masking. And it's projecting that sometime in late September or October, we will have over 100,000 active COVID-19 cases here in the state of Arkansas. And it really raises the question, are we moving in the right direction? Is our policy and implementation going to make this even worse? Or are we going to foster the courage to do what is necessary to flatten the curve, as you said, and save lives here in Arkansas?
Well, what is necessary, Doctor?
Well, it's pretty simple. You know, we need a more dedicated federal response with respect to testing and implementation of protective equipment and resources that the states need. And we need to understand that masking is not a political issue. It's a scientific issue. It's proven to work. Social distancing is a scientific issue. It's proven to work. And it's really difficult to make the case to somebody in a town like Little Rock that they need to wear a mask if there's a town 30 miles away where masking is not required. It creates a situation in which people don't know what to believe. And we really need a true north right now in terms of what is required socially for Arkansas to flatten that curve and to allow us to do the things that we need to do as a society, educate our kids, go to work, and take care of each other.
Well, in terms of the state response, sir, has the state, question obviously has political overtones, there's no reason to avoid saying it, has the state been aggressive enough in its standards, in its policies?
Well, Governor Hutchinson has made it clear that everyone should be masking. I think that there are mayors who have listened and who have reacted in the right way, including Frank Scott here in Central Arkansas. But I think a uniform policy across the state for masking is what's going to be needed to bend the curve for the entire state.
All right, Dr. Joe Thompson, your thoughts.
You know, see, this is a virus that's very infectious, and it is spreading in our communities, and we are at risk of losing control. We are testing more, so we're finding more people that are infected, but the indicators that are most concerned to me is we have breached that 10% positivity threshold 5 times in the last 2 weeks. We are seeing a 20 to 30% increase in hospitalizations and ventilator use week over week. testing more people does not cause more hospitalizations and more ventilator use. That's more people becoming sick and succumbing to the effects of this virus. I seriously believe we are at risk of losing control and that the masking issue needs to be put aside, and we must do everything we can to have universal facial coverings. The models that have been put forth by others, the Seattle group, Goldman Sachs on the financial basis, are in alignment with UAMS's models. They just put price tags in terms of the economic impact, that if we continue on the current path, we're going to revisit the need to have the reductions before. Last thing I'll say is on the education front, as we look to open schools, there is no question that every superintendent in the state should strive to have as many students use facial coverings when they cannot achieve 6 feet and guarantee distancing. Schools need to not question whether facial coverings should be required to reopen this fall.
Dr. Dillaha, the epidemiologist, now those are pretty ominous projections there from Dr. Thomas. Dr. Thompson, you concur?
Yes, I think it's going to be very important for all facets of our communities to work together, not just schools, but families and businesses. So businesses also need to require their employees and their customers to wear a cloth face coverings to protect their communities. Their workers will go home. If they're not protected, they may transmit the virus to their children. Their children would bring it to school, or vice versa. So it's going to be really important for all facets of our communities to work together simultaneously in order to prevent the spread of COVID-19 in our cities and towns around the state.
Let me go back to Dr. Thompson for just a second. Doctor, are you advocating here a stronger executive action, either through directives, a mandatory, statutory action?
Well, Steve, I think you have to understand where the authority is and then where the amplification opportunities are. Yesterday, the governor and Secretary Key put out a framework for schools to reopen. There is shared responsibility between the state and local school districts, with much of the decision-making authority being at the local school districts by the superintendent and local boards of health. So those local leaders must be educated, must be engaged, and must take action if we're going to prevent continued growth and spread of this virus across our state.
If I can go back to Dr. Patterson for just a second. Dr. Thompson a moment ago said we are literally on the edge. Let me have your take on that.
We are clearly on the edge. You know, we are seeing an upslope in our state, and the number of active infections, as Dr. Thompson mentioned, increase in the number of hospitalized patients, increase in the number of patients with respiratory failure requiring ventilatory support. We are on the edge with respect to our ability to manage patients who are coming into our facilities right now. The intensive care unit here at UAMS is completely full, and we know that the number of cases is going to continue to rise over the coming weeks. And we're on the edge in terms of the impact that this has on our communities, our churches, our societies. We're talking about potentially 20,000 cumulative deaths here in the state of Arkansas. If we fully comply with masking policies, we could reduce that by almost 75%. That's the edge that we're on.
How real, how imminent is the threat to emergency room care and intensive care from other maladies or other treatments because of the coronavirus crowding out patients with other ailments?
That's a real concern, Steve. And when I think of this from the perspective of a hospital leader, there are two concerns that I have. One is safety. Can we manage all of our patients and manage our staff and family members in a safe way while this pandemic is going on? And secondly, our capacity. Now, we've learned a lot about how to manage patients safely. So we're pretty confident that we can go about our business for all patients and take care of them without risk of exposing them to COVID-19 or other infectious problems. The concern that we have going forward is capacity. And that capacity is the number of beds we have, but it's also the number of ventilators that we have, the resources that we have to take care of patients, and the protective equipment that's necessary to manage patients with respiratory infections. Our capacity is not unlimited. And at some point, while we may have the capacity across the entire state, we may have the resources across the entire state to take care of every COVID-19 infected patient, those resources are not necessarily going to be in the right place. So as this progresses, we are going to see capacity constraints and limitations on our ability to provide care unless we effectively bend the curve soon.
Dr. Dillaha, I noticed this morning there was one statistic I read where the state that measured states individually by their testing capacity, and it was at goals where they should be. And Arkansas was at about 39% of its target testing rate. Is there any hope of getting that, of raising that number in the very near term?
Well, the capacity in Arkansas depends in many ways in the capacity of the United States. Many of our healthcare providers use commercial labs that are located out of state. And at this time, those commercial labs are constrained because of the availability of the reagents or the chemicals or the supplies they need to run the tests. So we are working within the state to increase our capacity at the health department. UAMS is also doing their part, and local providers, but it's that supply of the reagents and things that are needed to run the tests. And because of the surge in the U.S. as well as the state, it's really constraining that supply so that we can get the tests done in Arkansas that we need to do.
Is this, again, as Dr. Thompson alluded to, or Dr. Patterson, I think both gentlemen maybe, there does seem to be an absence of national coordination here, and the governor has complained about it repeatedly. Dr. Dillaha, is this at the core of the problem here in terms of PPE, test kits, and the like?
I think national coordination is really very important, and there is more that could be done, and the country as a whole, states need to coordinate among each other because we have overlapping hospital systems, but we also need that from our federal partners.
Dr. Joe Thompson.
You know, Steve, our nation was politically polarized before this novel virus came onto our continent. It's novel. Our immune systems have never seen it before. They don't recognize it. It's a tricky virus because you can be infected and spreading it and not even know it. We need national leadership here to come together and say this is a threat. We need to overcome the political polarization that was here before, and we need not to play games here. If I can say anything, this is a threat to our economy. This is a threat to our families. This is a threat to our individual health moving forward. And we do not need to have this become a political football, as unfortunately it has been.
Dr. Patterson.
Yeah, I agree with everything that has been said. It reminds me of my own experience during the beginning of the HIV epidemic. And the truth is that while there were some political overtones to that situation, there was never a debate about whether medicines or condoms or protected sex were beneficial. And we have turned science in many ways upside down as we have dealt with this. And when you hear somebody like Anthony Fauci being out of step with the administration in D.C., it sows confusion in individuals across the country and has made the conversation about what is the right thing to do scientifically and socially incredibly difficult.
I want to take just a moment and go to Dr. Dillaha because I have been reading that across the country, perhaps even in Arkansas, a number of parents who otherwise would have their children immunized against DPT, the customary childhood immunizations, are becoming increasingly reluctant to do that for fear of going to any medical facility or for fear of the vaccines themselves. Could you address that? Are you seeing that? Is that a concern of yours?
Yes, we have seen a decrease in the number of doses of childhood immunizations given in Arkansas during the time of the pandemic. It's a complex issue. There have been fewer opportunities to get vaccinated because many clinics were closed at a period of time. But we are seeing an increase in the debate about the safety of vaccines, and vaccines are actually among the safest pharmaceutical products out there. But the organized debate of anti-vaccination is increasing along with some of the other anti-science debate that is occurring in this country. And we see it now in the COVID-19 pandemic and how we are responding to it as a country. We do encourage parents to go ahead and get caught up on their children's vaccines. The healthcare system now has adequate PPE in terms of providing protection for them and the health professionals and giving the immunizations. So this would be a safe thing to do at this point in time. It's going to be riskier not having the children vaccinated. And of course, we want to make sure we maintain the herd immunity that we need, because the last thing we need in Arkansas is measles and COVID-19. So it's going to be very important for us to get caught up on the childhood immunization rates.
To any of our guests, and I'll begin with Dr. Thompson here, one trend that appears to be fairly national in scope is that those who are being diagnosed, testing positive, tend to be younger and better able, it would appear, to withstand the ravages of COVID-19. Their recovery rate is better. Is that of any comfort to you, Dr. Thompson?
Well, Steve, I think a few things there. Early on, because of limitations, we only tested older individuals or those that had risk factors. So now as we test a broader population, we're going to see more younger individuals that were infected and that we discover that. I mentioned that this is a tricky virus. It is very infectious, but in half the people that contract it, they don't get symptoms. And many of those are in our younger populations that are socially mobile and socially active. And so they don't see the risks because they don't have friends that have actually had those risks. The transfer of that virus from our younger age population, which now over 50% of the active cases are below age 44, transmission of the virus from those younger individuals that have more resilience, less impact, to older populations, we're going to continue to see our hospitalization rate go up, ventilator rates go up, and unfortunately our death rates go up.
So, Dr. Patterson, it's not even qualifies as cold comfort, I suppose.
Well, I think that we can't be complacent about the spread of virus in populations who seem to tolerate it very well for all the reasons that Dr. Thompson just articulated, but also viruses are not stable entities. Viruses change over time. We're seeing some evidence that the virus that's spreading in Houston is more virulent due to changes in the viral sequence. And those changes can be selected for. So populations like young individuals who might have seemed impervious to the serious consequences of the virus might suddenly be very susceptible to the serious consequences that we're seeing in older individuals with heart disease, liver disease, lung disease.
Dr. Thompson, Dr. Dillaha, or did you want to get in on that? I'm sorry. I thought I heard.
Yeah.
Go ahead, please.
Yes. I did want to add to that. There seems to be a misconception that if people are infected, then they'll be immune from this virus. And we know that when people recover from the virus, they must have some immunity, but it's not demonstrated yet that we will develop lasting immunity to this virus once we have it. So it's possible we could get it over and over again in much the same way that the other coronaviruses that cause the common cold, we can get them over and over again. So it's a risky thing to allow the virus to continue to circulate. It offers more opportunity for mutations, but in addition, it does not offer any assurance that we will develop herd immunity or that the person who has had it before will not get it again.
Well, I read also, doctors, that even among the young who do recover, there is some early evidence anyway of quite possibly some lasting damage to the pulmonary, to the lungs, perhaps even to the brain. Do you concur? Dr. Patterson, we'll start with you.
Yeah, so, we have the most experience in the United States in large populations in New York City because the outbreak happened there so early. And as you know, I worked in New York for a number of years at New York Presbyterian Hospital. My colleagues there are talking about long-term sequelae, even in patients who are not severely symptomatic, but yet have long-term changes to their lungs, but also long-term changes to their heart. There appear to be long-term sequelae in the central nervous system. We got a lot to learn about this. We're still very early in the course of our knowledge about this disease in the United States, but we do need to anticipate that the long-term consequences may be as bad or worse for us from a national healthcare standpoint as the acute consequences.
Well, back to schools, which Dr. Thompson mentioned just a moment ago, that we're now, about 5-6 weeks away from opening schools, excuse me, because the governor extended, just within the last couple of days, extended the school opening day, date by about a week. Dr. Patterson, starting with you, much is being left to local school districts, local superintendents, local school boards. Is too much being left to them?
I really don't know enough about the balance of how that's going to work in actuality to weigh in on that. But I would say that we do have worldwide experience in reopening schools in ways that are safe. We need to learn from that experience, and whether it's local districts or whether it's the state government, we need to apply that knowledge in a science-directed manner. But I would also be remiss of me not to point out that no place has opened schools, no place in the world has opened schools with a rising rate of infection. So no matter what we do, we need to be prepared to be surprised, and we need to put as much effort into our plans to shut down schools right now as we're putting into opening them up, because inevitably we will have to shut down school systems once they've opened up if outbreaks occur in those school districts.
Dr. Thompson, your colleague says it's inevitable, or all but. You concur?
Well, Steve, I want to offer some optimism. This has been a pretty strong call to action, but Dr. Patterson mentioned worldwide experience. The European Union and the United States both experienced the same initial spike, but today the European Union is going to have about 4,000 to 5,000 new cases a day, and the United States is going to have 55,000 new cases a day, and they have a third more people than we have. So this is controllable. They don't have any tools that we don't have. They don't have any medicines that we don't have. It's about hygiene, distancing, and wearing facial coverings. They're at 4,000 new cases a day for a population that's a third larger. We're going to have 55,000 new cases today. It's pretty simple what needs to happen.
Well, the Arkansas Education Association has issued a statement late this week that indicated grave concerns on the part of teachers about reopening, absent more stringent standards. Is that concern justified, Dr. Thompson?
I think this virus is just as virulent, unless we have a new virus that Dr. Patterson mentioned. It is just as infectious as it ever was. Our bodies have never seen it before, so we are just as susceptible as it ever was. And it's far more pervasive in our communities than it has ever been. Unless strong precautions are put in place and the things that we know work are adhered to, it is a threat that should warrant concern.
Dr. Dillaha, I'll give you the last word. We're about out of time.
So the most important things that we can do in our communities is to wear cloth face coverings whenever we're out in public, and to social distance and avoid going places we don't have to go. And that means when school starts or other things, we need to pay attention, because we do not want to be going other places that's going to increase our risk for introducing the virus to school or to work or to our families.
Don't you want to mention hand washing too, Dr. Dillaha?
Hand washing for sure.
All right. Doctors Thompson, Patterson, and Dillaha, thank you so much for being part of the broadcast tonight. Thank you, and come back soon. And we'll see you next week.
Support for Arkansas Week provided by the Arkansas Democrat-Gazette, the Arkansas Times, and KUAR-FM 89.